Okay, I think we'll go ahead and start. We stopped yesterday at problems with red blood cells, erythrocyte disorders, things that go wrong. These are the interesting things when things malfunctioning. We can group red blood cell problems into two categories, either an anemia or a polycythemia. Remember, anemia is simply a symptom of an underlying condition. It's not the disease itself. There is no technically a disease called anemia, and it is a response to a problem. Anemia is a response to a problem. Anytime a patient is not carrying enough oxygen in their red cells, we would say that they are experiencing anemia. The underlying problem is, why don't they have enough oxygen? Why aren't the cells getting enough oxygen? Is it because there aren't enough red cells? There's not enough iron? Cells are being destroyed ahead of time? Any number of these problems could be going on here. If someone could be bleeding out slowly through bleeding ulcer or an intestinal bleed of some sort. Okay, so we're losing red cells there. Person's going to have symptoms of anemia. Anemia is, so they're going to be tired. They're going to probably appear slightly cyanotic. The nail beds would be slightly blue. The lips may be slightly blue. If nothing else, they may be. Nail beds are not usually nice and pink. They may be pale. They may be close to being white before they can. Maybe they're not cyanotic. Maybe they're not bright pink as they should be. So we don't know. So they're bleeding out. They have difficulty breathing, dyspnea. So they have tiredness, they have paleness in the membranes that count. Dyspnea, they have difficulty breathing. They might be gasping for breath, because if you don't have enough red cells, you're not going to have enough oxygen to support the tissues. And so your patient may be have great difficulty doing something simple like walking up a flight of stairs or getting out of a chair. Discover that they're very short of breath for that. They don't know why. And they may be cold. Not enough oxygen means not enough cellular respiration, which means not enough body temperature. Always seems to come back to cellular respiration in here. So it's either blood loss, not enough red cells, or we're breaking them down too fast. Blood loss is sort of usually easy to notice, particularly if it's a penetrating injury in an artery on the surface. We can see that, hey, they're bleeding out. Okay, there's your blood loss. It's sort of hard to focus on, well, they might be experiencing signs of anemia if their artery is spurting out and blood's going everywhere. You have other things to worry about at that point than just, well, they might be showing signs of anemia too, because you're losing a lot of blood. Dead in 5 minutes if you don't correct it. However, we do treat that. We treat it with fluid replacements. Fluid expanders. We give blood if someone's bleeding out. We try to control the bleeding. Whether it's surgical intervention, whether it is direct compression on the wound, whatever we have to do to stop the bleeding. That's the first thing. Then we replace the blood. But we have to find out where the bleeding is coming from. We have acute bleeding. That is, a laceration in the arm or in the body where you're losing arterial blood. But you have chronic bleeding also. This is the sneaky. This is one that will take your patient out with a whole lot of symptoms, fatigue, chills, and difficulty breathing and paleness. And they don't know exactly what's going on, and they just don't feel good. You have a bleeding ulcer. You're going to lose a little bit of blood. An ulcer, bleeding ulcer in your stomach. There is a bacteria that may invade your stomach called Helicobacter pylori. That's the bacteria that causes ulcers. Ulcers aren't caused by stress, or caused by a bacterial infection. And if that ulcer, if bacteria takes hold on the lining of the stomach wall, what it will do is eliminate the mucous membrane, we have a very thick layer of mucus that surrounds the inside of our stomach because we're producing hydrochloric acid. Hydrochloric acid with a pH of 2 is pretty powerful stuff, and it will burn through tissue, but we protect our stomach with this very thick alkaline mucus to neutralize it. Well, if we burn through the mucus and then we get to the membrane, now the membrane of the stomach is held together with tight junctions. They're stratified squamous epithelial cells in here. So it's a very thick layer. But if we start burning through that, dissolving away this layer with hydrochloric acid, we're going to get blood vessels. Remember, the blood vessels are located in the dermis, not in the epidermis, but in the dermis itself. We get to that layer, we're going to be bleeding. We're going to dissolve away tissue, and we're going to have blood oozing out from this ulcer. It's pretty painful, I'm sure, to have an ulcer to begin with, but also to have it bleeding. Now, if this is uncontrolled, it will continue. It's not going to stop on its own. It's going to continue to bleed, and it's a slow trickle. But your patient's going to be exhibiting all these signs of anemia, the chills, the fatigue, the pallor, the dyspnea, and their feces will probably turn black, look like coffee grounds. That's one of the characteristic signs of bleeding, and they can die from this. Something as simple as an ulcer in the stomach can kill your patient because they're bleeding out slowly. Hemorrhoids, which is a lesion that forms on the outside of the anus, near the rectum. Blood vessels there can become distended if a person puts too much pressure on their butt, if you will. Because blood vessels don't like to be compressed constantly. So someone who sits a lot may develop these hemorrhoids. These blood vessels may be compressed over and over again. Blood starts to slow down inside there and collects. And then eventually it can form a lesion. So it oozes out, start oozing blood through the lesion. I've got some really nice graphic pictures to show you when we get into blood vessels about what a hemorrhoid looks like. I'll make sure we do it before lunch. So, but it is a problem. You know, a hemorrhoid is inflamed tissue. These vessels distort, they distend, and they start leaking. That's where the blood loss comes from. Hemorrhoids are the counterpart of varicose veins. Varicose vein is the large vein in the leg. They usually don't leak this hurt, but a hemorrhoid can start bleeding if you have enough pressure, enough weakness in the vein around the rectum. And so, you know, what an embarrassing cause of death. Well, they died from a bleeding hemorrhoid, you know, but it can happen. They usually had chronic illness, but it isn't much, but it will continue, and it will continue. And you know, these little trickles of bleeding out cause problems. So here we have, we're going to have all the signs of anemia. It'll be gradual and may accumulate over time. I had a friend from high school that died from a bleeding ulcer. You don't think about it, but it does happen. So they bleed out, and you know, but they've had all these warning signs, so you have to correct it. But the bleeding ulcer usually has to be corrected surgically. Now, not every ulcer in your stomach is going to be bleeding. Lots of people develop ulcers. It used to be that you had an ulcer, you would drink milk and eat eggs and think happy thoughts and stare at a fish tank because watching a fish feel better. Everything, it was all pointed at stress and stress alone. So if you de-stress yourself, your ulcer will go away. Well, it's bacterial. You know, 2-week course of antibiotics clears up the bacteria. So now, did the stress contribute to an opportunistic bacteria to come along? Maybe. Point is though, if they have an ulcer or a hemorrhoid that's bleeding, you have to correct that, because chronic bleeding in its own way may be just as detrimental as the acute type of blood loss. That's one type of blood loss, or rather anemia. A second type of anemia is iron deficiency anemia. Again, it's a symptom. You're not producing enough red cells because you're not producing viable, useful red cells because you don't have enough hemoglobin. You have to have iron to make hemoglobin. The iron allows the hemoglobin to carry oxygen. So if we don't have enough iron in the diet, then we're going to make red cells, but we're not going to have them packed full of hemoglobin. You can see all these red cells here, but many of them are, have low levels of hemoglobin present. So we can't carry as much oxygen. And this is another one of those relatively easy fixes. If they are iron deficient, what do? Iron infusion, that's the ultimate right there. It may be something as simple as iron tablets or a multivitamin with iron, or maybe just some more beef or something like that. That's probably the most fun part about it. But the problem is an absence of iron. You've got to have iron to make hemoglobin. So now you have less hemoglobin, which means less oxygen. So you're going to have the same characteristic signs of anemia, fatigue, shortness of breath, paleness, all the characteristic signs here. But this one is caused by a lack of iron. Another type of anemia deals with not producing enough red cells. This is called pernicious anemia. And this used to be fatal, probably 80 years ago. This was a fatal condition. Pernicious anemia is an autoimmune disorder. We attack our cells in our stomach. Comes back to our stomach again. Our stomach produces a compound known as intrinsic factor. We have these little pits in our stomach where we secrete the hydrochloric acid and pepsin and intrinsic factor. And intrinsic factor allows us to absorb vitamin B12 in our diet. You have to have B12. Any good multivitamin that you buy, on the backside of the label, when you read it, it always tells you how much B12 it has in there. Remember, B12 is a water-soluble vitamin, but we still need it. B12 is essential for red cells to divide in the bone marrow. So without the B12 present, we're not going to get red cell production because the production of the red cells takes place in the red bone marrow. It's stimulated by erythropoietin, and the stem cells are going to be ultimately dividing to give you more and more red cells. Well, without B12, they can't do that. So treatments, well, injections of B12, one way to bypass being absorbed in the stomach, because if the stomach is not producing an intrinsic factor, it's not going to help you eat a whole lot of liver, cooked liver or beef or something like that. Because the intrinsic factor isn't there, so you work around, you get the B12 automatically in the system through an injection. Now, a milder form of this with B12 can occur if you have a patient who is a vegetarian or vegan, who is very strict vegetarian and avoids all forms of food like beef is high in B12 and also in iron. And so your vegetarian or vegan may have issues with not having enough B12 in their diet simply because they're not eating the right combination of foods. In AP1, we talked about how a vegetarian has to combine food groups to make sure they get all their amino acids. We have, we don't have all 20 amino acids made in our body, so we have to go the easiest approach to get all 20 amino acids. If you are not going to eat foods that contain complete proteins like beef or fish or chicken or dairy, they all have proteins with 20 amino acids. Then you have to mix and match. You have to have grains, cereal grains like rice or corn, or wheat. You have to have plants like beans and peas. Between the two of those two groups, you'll get all 20 amino acids. You have to combine this. But, you can still be a vegetarian or a vegan, but you have to eat selectively so that you get a certain number of amino acids from corn and a certain number of amino acids from beans. Corn and beans, very, very common diet around the world. Beans and rice, even better. Very healthy diet gives you, as far as the amino acids that you need, you're going to get all of that. So, same thing applies here with B12. You have to be selective, make sure that you're getting your B12 somewhere. And it used to be that pernicious anemia had no cure. There was no way to treat your patient other than having them eat raw calf's liver every day. Why raw calf's liver? Because the calf would take in large quantities of B12, would process it, and it would go into the calf's liver. You couldn't cook it because if you cooked it, you destroy it. So your choice is, I want to die or I want to eat raw calf's liver and want to die. So can't imagine what that would taste like. Everything liver. Yes. Okay. So, liver cooked up isn't bad. No. Anybody ever chicken livers? Okay, chicken. Okay, yeah. Okay, so you know what I'm talking about. KFC still sells chicken livers. So, the point though is that the reason you had to have it raw was because the B12 had already been processed. The cows and factor had already worked on it. And it absorbed the B12, and you get this big dose of vitamin B12 from eating the calf liver. So that was the workaround 80 years ago. Now it's not necessarily, it's not the near fatal or fatal disease that it was back in, let's go back about 100 years or more before we get that. But it can still be a problem. The red cells will not undergo mitosis in the bone marrow without the B12. So you have to have the B12 there. Another problem. Suppose the kidneys decide not to produce erythropoietin. Remember, the kidneys are a great monitor of our blood. And our whole blood supply goes through our kidneys every 45 minutes. And we filter our blood between 60 and 80 times a day. And the kidneys are going to monitor red cell production. They're going to monitor, they can monitor oxygen levels and red cell levels. They can monitor blood pressure. They can stimulate erythropoietin to be released to make more red cells when our oxygen levels drop. So the kidneys are always keeping track of what's going on. What better place? What other organs are going to filter our blood? Every 45 minutes, our entire blood supply every 45 minutes. So, what if the kidneys aren't producing enough erythropoietin? Are they not detecting oxygen levels? Or maybe they're just not making EPO, enough of it. Because EPO is the stimulus to tell the bone marrow to make more red cells. So what if we're not releasing the EPO? So no, that would have been fatal 100 years ago. Now synthetic erythropoietin can be used in place of natural EPO, erythropoietin, to stimulate the bone marrow. As long as the bone marrow is working fine, it doesn't matter where the source of the EPO is coming from, either injected or tablet form, or some way to get the synthetic EPO in to stimulate red cell production. And it works. Now, another type of problem where we're not making enough red cells. The first problem was we saw that didn't have vitamin B12, so because we didn't have intrinsic factor, pernicious anemia. Now we had not enough EPO being produced. Here we have the bone marrow has been damaged or destroyed. We don't know why it could occur. It could be a virus. It could be exposure to drugs. Exposure to high levels of ionizing radiation will destroy the bone marrow and you won't produce red cells. We call this aplastic anemia. So with aplastic anemia, you just can't produce the red cells. You are generating all the EPO you can, but nothing's happening because the bone marrow has been damaged. It could be a malignancy, could be some sort of infection that suppresses the bone marrow. Whatever it is, and we usually don't know specifically what the cause is, the red bone marrow is destroyed and no red cells. And not only do we lose the erythrocytes, but we lose all 5 white cells and we lose the platelets. So we can't clot properly because we've lost the platelets, and we can't fight infections because we've lost the white cells. The white cells are our infection fighters. So aplastic anemia doesn't just shut down red cell production, it shuts down all cell production. So no bone marrow, no red cells, no bone marrow, none of the 5 white cells are getting produced, so we can't fight infections. And no platelets, so we can't clot. Because platelets are the first line, or the second line of defense we use when we have, a penetrating injury and we're bleeding out. We want to try and stop the bleeding. So the platelets go to work first. So how do you fix it? Well, you have stem cell transplants, bone marrow transplants. The bone marrow isn't working, so you replace it with healthy bone marrow. You get a donor. You go into the iliac crest and suck out healthy bone marrow and replace that into your patient, and it usually works. And I said usually, and it will take over production of blood cells, all 7 types of blood cells. Without that, or without transfusions of blood, a blood transfusion is a short-term fix, because a blood transfusion will give you mostly red cells. It may give you white cells too, but it's mostly red cells. The problem is that it's borrowed. Transfused red cells last about 30 days. White cells, which are not being produced by the bone marrow, will last a few days. So you're not only fighting lack of oxygen, but you're fighting no immunity and no clotting. So your patient has to have some sort of long-term approach. And it used to be that aplastic anemia was fatal because until the whole concept and development and use of stem cell transplants, bone marrow transplants became common, all you could do was transfuse them. And whenever you transfuse an individual repeatedly, you run the risk of some sort of infection occurring, usually at the site of the where you have the port going in for transfusing blood coming in. So that is aplastic anemia. Now we have a problem called hemolytic anemia. Now, lytic means lysis, means rupture. So hemolytic means a rupturing of blood. Hemo means blood, so hemolytic means blood being destroyed. Hemolytic anemia, you're destroying the red cells early. Red cells typically last for 4 months, but you are destroying them much earlier than that. This often occurs if you had hemolytic anemia will occur if you have an incompatible transfusion. If you're type A blood and you're type B blood, and you decide to give her a unit of your blood, you're thinking she's A, well, she doesn't like your blood. She doesn't like your blood. She doesn't like their blood. And so her antibodies will attack your blood. And so you'll have rupturing of red cells. Not going to affect you if you made a blood money, you don't care. But she may or may not be in a world of hurt here because the red cells are being, if you were transfusing blood for a purpose, for whatever reason you would have a transfusion, and her antibodies attack what they consider to be foreign blood, they're going to rupture all those red cells. And so you would have hemolytic anemia, you would be destroying the red cells and lysing the red cells. So nearly always going to be caused by some sort of transfusion that shouldn't have happened. Our blood banks in the hospitals go to great lengths to make sure that we don't have that happen, but it's still, some things still slide through. And you can never discount the ability of a patient to do something that doesn't appear to be dumb, but works out to be dumb. To explain that, years ago in Virginia, I had a friend of mine who was a lawyer for a major hospital in Northern Virginia, and they were being sued because a patient died from a transfusion mismatch. What had happened was that the patients, there were two patients sharing a room, a joint hospital room, and they had both sequestered their own blood for surgery. Well, the patient in the bed by the door said she'd really like to be by the window, and the one by the window said, I don't mind. So they switched positions. And during the night, somebody came in and transfused the wrong blood into the wrong patient. Now, you would think that you would be able to scan the bag, you'd be able to read the numbers on all the tubing, it is coded. Well, somebody did. Now, granted, the patient switching beds precipitated the problem, but it should have been caught. So, and my friend was in the very unenviable position of trying to defend the hospital, and there wasn't much he could do other than settle. But it happens. Patients do unusual things, but the system should still protect against that. So, yeah. You don't think there's all these warning signs around here just because people like to make warning signs, right? Every warning sign and label was there because something happened. Something went wrong. You ever been in a hotel room and see the sign, do not hang clothing on sprinkler heads? You ever wonder why that happened? Somebody probably hung something there and the thing broke and flooded. That happens all the time in Sevierville. Our campus floods routinely, so that's a different story. Okay. Transfusions that go wrong, infections that go wrong. The bone marrow can be infected and destroy its ability it can start lysing the red cells. There are two other conditions that can cause red cell destruction. It's thalassemia and sickle cell disease, what we call sickle cell anemia. You've definitely heard of sickle cell, I'm sure. Thalassemia is a different type of condition here. We're going to go into both of these. What happens is you are producing, in both cases, you are producing the wrong type of protein, the globin, to combine with the heme. So, thalassemia, much like sickle cell disease, it is primarily limited to people from one region of the world. In this case, it's from the Mediterranean. Here, in thalassemia, you have to have, multiple, have to have multiple globins. Well, you have one chain missing, completely missing, or at least defective. So you're missing a globin chain. This hemoglobin is the heme unit with the iron and protein globin. So what happens is that in thalassemia, you produce very fragile red cells. They look like red cells. They're very fragile, and they don't have enough hemoglobin in them. They don't work well. It can be very mild, very, very severe. You may have to have transfusions, What happens though is that the bone marrow will respond to this by enlarging the marrow. And so what we see here is a skull. See where the red arrow is? That's the frontal bone. Now our frontal bone is very thin. You can, in fact, also you can feel it right through your skin. The frontal bone will enlarge, and the frontal bone will protrude, if you will, because it's trying to compensate. Like a lot of things in our bodies, if it doesn't work right, it will get larger. The heart enlarges when it's weaker. Thyroid gland forms a goiter. Here we have an enlargement of the frontal bone, the forehead gets bigger, trying to produce healthy red cells. It can't because it's a genetic disorder. This is a genetic problem, and the bone marrow can't do anything about a genetic disorder. So the bone marrow will enlarge. It's not producing healthy red cells, but we're going to get bigger. We may trigger a red cell production in other parts of the body, but again, the problem is still a lack of the correct amount of globin to combine with the heme to make hemoglobin. So you treat them with transfusions. It's entirely possible now though to alter the DNA. So there are ways to do that. There are, with genetic engineering, you can correct the DNA at least temporarily. So, but the most common giveaway is going to be this enlarged frontal bone. Like I said, primarily people that come from the Mediterranean area in the world. So that could be Southern Europe, to North Africa, to the Middle East, including Spain, anywhere along in there, people that have descended from that region. Why that region? I don't know. But that's the region where most of these defective genes have come from. Now, the other type of disease is sickle cell disease. So there's normal hemoglobin is produced in a healthy individual, but a person who is descended from whose descendants extend back to sub-Saharan Africa, this is the geographic region here where sickle cell comes from, will have one strand of hemoglobin that is mutated. We call it S hemoglobin. And so this hemoglobin, and it's a very subtle mistake. In AP1, I talked about the number 6 amino acid in the chain. The amino acid chain to make hemoglobin is about 360 amino acids long. The number 6 amino acid in the chain. So you have, here's your amino acid 1, then 2, then 3, 4, 5. Here at number 6, it's supposed to be glutamic acid. But instead, it's valine. Now, they are very similar in structure. They're very similar in makeup. In fact, let's go back in the distant past. And if I say codon, just nod your head and say yes, thank you. So the codon for glutamic acid and the codon for valine are only one base apart. So it's a very subtle mistake here. But in sickle cell disease, we substitute valine for glutamic acid. And that one little mistake, right at the beginning of the chain, completely damages the entire hemoglobin, making it essentially reduces its oxygen carrying capacity by about 80%. So we had just one subtle mistake, and it is so microscopic because it really is one base difference in the codon, that's coding for that particular amino acid. So what happens is when the red cells form and they get stressed, you're exercising, you're walking up a flight of stairs, you're coughing vigorously, normally the red cell, has that oval, shape like this, or we look at it from the side, it looks like a biconcave disc. What'll happen here as a person with sickle cell disease, having full-blown sickle cell, the red cell instead becomes crescent shaped like this, becomes brittle. Now there are two versions of sickle cell. If you have just one defective gene, it is a homozygous recessive disease, meaning you have to have two recessive genes to have the disease. You have to receive a recessive gene from your mother and from your father to have full-blown sickle cell. You can be a carrier and just have one gene, and you may have symptoms, you may have no symptoms. But what will happen is if you have full-blown sickle cell, then anytime you become physically stressed, then your red cell is going to form this shape like this and drop its ability to carry oxygen. The red cells, they look like, the little crescent shape you see here. They can't, their carrying capacity is reduced by about 80%, and they're not squishy anymore. Remember, normal red cells are squishy. They can slide through capillaries. Capillaries are really the tiniest blood vessels, and they're just capillaries are only one cell layer thick themselves. But the red cells can squeeze through a capillary like a water balloon, change their shape and pop out the other side of the capillary, and they're fine. But sickle cell red cells are brittle and they're sharp, and they're going to have trouble going through the capillaries, and they're going to hurt, particularly in the joints. And so now you're not carrying enough oxygen, and it's painful. It's very painful. So you don't get enough oxygen. You have all the symptoms of anemia there, and you have a great deal of pain. And since it's a genetic disorder, it's not going to get better on its own. Yes. No. No.
All the blood work has it. All I know is that it's red blood cells are
Okay.
and it's, you gotta understand. So I don't know much about the background.
I have never heard of that. So that one I'll have to look up. So yes. So just about anything's possible.
Oh,
Yeah. So.
like some of the that cancer too, and then definitely more taking cause of
Okay.
along the lines of
Do they? I wonder if because they're shaped like that, they have more difficulty getting through the capillaries. Do they break down sooner than a normal cell? With two spleens, that's even more unusual to have that. So.
penicillin for a while, the sisters that were drawn off of it, and I'm just wondering, I mean, when you get sick, like the white blood cell, his white blood cell count is like way up because it doesn't come to sleep.
No, that one intrigues me. I'll have to look that one up. So, okay. Again, there's nothing. Pretty much nothing's impossible. So, what happens with sickle cell? The cells don't last long. We're supposed to last 120 days. These last about 10 or 20 days. They won't bend under stress and flex like a regular red cell will. So they're going to pile up in the capillaries. They may cause clotting to occur. They're not carrying enough oxygen, so your patient's going to be tired. Their energy levels are low because they're not going to have enough oxygen for cellular respiration. So they're always going to be short of breath and cold. They have great difficulty doing normal things like walking up a flight of stairs or walking out to the mailbox, for whatever reason. So they're constantly tired. The, and the cells look like this. It's the normal red cell on the left. That is a sickle cell disease red cell on the right. This is when it's under oxygen stress, when you're exercising. When the demands for oxygen go up, the red cell assumes this brittle crescent shape. Now, who gets sickle cell? Well, predominantly, it's descendants of sub-Saharan Africa. You know, it would be easy to say African Americans don't. Well, no, it's anybody in the world that is descended from sub-Saharan Africa. Primarily confined to people like African Americans in the U.S. Or any other Black person around the world would carries this disease. Why? Well, it turns out, and this disease is pretty unusual. It should have disappeared a long time ago. But what happens is that sickle cell disease, if you are a carrier, you don't have the full-blown disease, but if you're a carrier, it gives you immunity to malaria. Malaria is a major killer in tropical regions around the world, particularly in the area below the Sahara Desert in Africa. You know, where you get close to the equator, and you have more tropical and subtropical conditions. A lot of water, which mosquitoes, we all know mosquitoes love, because mosquitoes carry malaria. The strain of mosquitoes do that. Now, if you were the carrier for sickle cell, you wouldn't die from malaria. You might not have any sickle cell symptoms, but you wouldn't die from malaria. A lot of other people do. Millions used to do. Still 2 or 3 million die every year. Anyway, we even have some cases of malaria in the United States every year, which is pretty unusual because we haven't had it for years. So having this negative trait protects you from malaria. Well, normally malaria would have cleaned out whole population to begin with. People that had traits that survived, so that kept the negative trait in the population. And so as long as that negative trait was there, as long as two individuals had the trait but not the disease, and they obviously remained female, and they could produce children that had the disease. And so the disease stayed around. So it could have gone away, but for whatever reason, the trait protects against another killer. So how many people have the trait? Well, in the U.S., it's 1 out of every 13 African American children have the trait. The odds are better to have the trait than they are to have the disease, because the disease shows up in about 1 out of 365 African American children. So it's primarily confined to that population group, the African American group, or Black people around the world. It isn't just in the U.S. But it could, it simply because of there was an endemic in sub-Saharan Africa. It could be that sickle cell disease was providing, the trait was providing protection against malaria, and that allowed it to thrive. Who knows exactly why it happened? However, you can treat it. Bone marrow transplants can take out the defective bone marrow that's producing the defective hemoglobin. And so you're still a carrier. You still have the genetic, you're not altering the DNA, but you can take out the defective bone marrow and put in healthy bone marrow and produce healthy hemoglobin. So that's a strong possibility there. Here's what it looks like. These are the red cells. See how they're piling up in the capillaries there? And normally they would go through, they slide through very easily, but they're piling up in here. Here we see how the bone marrow is producing these red cells, but then as they assume their crescent shape, see how they're clumping together inside there. These are all red cells clumped together because they don't have enough room to get through. There are, as I said, there are ways to do it that are pretty effective. Questions about sickle cell disease? Okay, let's go on. Now, here's another condition known as polycythemia. Now, here instead of underproducing hemoglobin, like in causing various conditions resulting with anemia, here we have an abundance, an overabundance of red cells. It is a malignancy in the bone marrow. It is sort of like the counterpart to leukemia, where leukemia overproduces white cells and not enough red cells. Here we're overproducing red cells and not enough white cells. We overproduce red cells to the point that our hematocrit, the measure of red cells and plasma in our blood, which should be about 45% red cells in a sample of blood. We talked about that last week in blood lab, would be somewhere around 80%. So you had a test tube full of blood and you spun it down, it would be filled with packed red cells almost at the top of the tube, the amount of plasma. It's a very thin layer of plasma present there. So your blood is very thick, it's viscous. It's the difference between chocolate syrup and motor oil. It's a very thick motor oil or a sludge, trying to push and sludge through your blood vessels. The difference here. So a blood smear should not look like this. These are packed full of red cells. Most of these are not fully formed, they're not mature, so they can't carry an adequate amount of oxygen, but they're prone to clotting because there's so many of them. And your patient that develops polycythemia will develop clots in their spleen, it will amplify any heart disease, it will trigger heart disease because we will, instead of cholesterol accumulation in coronary arteries, we're going to have these clots of blood from the same thing, filling off heart muscle. It will clot in the extremities. If it's not caught quickly, your patient may end up losing an arm or a leg because the clot forms so quickly and it's killing tissue downstream of the clot because they're not getting nutrients, they're not getting oxygen. So it used to be fatal very quickly. There wasn't a lot of ways to treat it. Now people that have polycythemia can manage the disease better. And of course, again, to come back to bone marrow transplants, you irradiate the bone marrow and kill off the stem cells in the bone marrow because that's what's producing these. That's what the cancer is, the malignancy. And you do a transplant of healthy bone marrow. Another approach, a short-term fix, what we call therapeutic phlebotomy. Now, 200 years ago, we used to bleed people when they were sick. The thought was that if we bled them, that people were sick because they had too much blood. George Washington died from a sore throat. He had strep throat. He died because his physician, using the best practices of the time, drained out his blood to try and pull the infection, not the infection, pull the bad blood out, the bad, what they call the bad fluids out. And he died. Nobody dies of strep throat, at least not lately. But so 200 years ago, bleeding was a common practice, and we stopped bleeding people. Now we're back to doing it because this has a purpose. Therapeutic phlebotomy, draining out excess blood. This is a short-term fix, not a short-term, it's not a fix. It's a short-term action to reduce the hematocrit down to a manageable level. Because you have all these packed red cells here, most of which are immature and can't carry oxygen. Plus, if you're producing, if 80% of your blood is red cells, you are tremendously underproducing your white cells. So you have very little protection against infection. And so it's not a very common condition. Uh, but it does occur. Probably not. You probably wouldn't be allowed to donate. Not that you could pass the infection, pass it on. But well, it's actually, it is a malignancy, so who knows? So, no, you probably couldn't. But it does create all sorts of complications that occur. Now, there is a condition known as secondary polycythemia, which is not malignant, which occurs when, for example, if you were to go to take that vacation trip to Estes Park, Colorado, because you want to see the town park of Gatlinburg. You know, you're 10,000 feet elevation, you can't breathe because the oxygen content in the air is cut in half. And after a couple of days, you start feeling better because you are overproducing red cells in response to the low oxygen. So you're producing a lot more EPO from your kidneys, and all of a sudden you feel better because you have adapted to the higher elevation with lower oxygen content, so you carry more red cells. You have experienced polycythemia or secondary polycythemia. It's fine. And then you come back from 10,000 feet back to 1,000 feet elevation like we are here, then eventually the red cells break down after 2 or 3 months and go away. But for a couple months after your trip to Colorado, you feel really good. You got more red cells. There is a bad side to secondary polycythemia. It's called blood doping. Blood doping is when an athlete, when you take synthetic EPO before an event, to give them more red cells so they can compete better, they have more oxygen available for more energy, or they can have their own blood sequestered and then transfused back in for the event. Now, it's easily detected. You know, all you have to do is do a hematocrit on your athlete and say, well, look at that. Last week your hematocrit was 45. Today it's 85. What happened? So it's cheap. Now, the Olympics are coming up in Paris in next month, maybe. They keep advertising. I lost track of when it's coming. There will probably be some team caught cheating through blood doping. It happens. You know, every Olympics, there's somebody that thinks some team that thinks they can get away with it. About 2 or 3 Winter Olympics ago, the French cross-country ski team was caught blood doping. They actually sent the coach to prison, so we take it very seriously. But it can occur. Now, normally we would administer EPO to a patient that needs more red cells. Cancer patients frequently need more red cells and carry more oxygen because whether it's their bone marrow or whether they're just fighting with the malignancy itself, you know, there's nothing wrong with administering EPO as needed. What's wrong is when they try to cheat with it. Okay, questions about red blood cells? No questions? Okay. So let's move on then to the white cells, the leukocytes, the white blood cells. There's 5 different types of white blood cells. They have a nucleus. Every one of them has a nucleus and organelles. They are the only complete cells in our blood. Red cells don't have a nucleus or organelle. It's just a sac of hemoglobin. Platelets are only cell fragments, with the white cells, all 5 types of white cells will have a nucleus with a very distinctive shape and will have organelles. Most of these white cells will not divide. Most of them are continued to be made from the bone marrow as we need them. Now, some, what we call memory cells, will divide and keep that line alive throughout our lifetime. We'll get into that when we talk about the immune system. Generally, in a microliter of blood, what you see there, we're going to have, yes, somewhere around 5,000 white cells. Microliter of blood will have 5 million red cells, 5,000 white cells, and 500,000 platelets. Remember the 5. So we don't have a lot of white cells in our blood. We don't make as many. And most of our white cells don't hang out in the blood anyway. They hang out in the lymph nodes. They hang out in our tissues fighting infections. They have an ability to move. Well, first of all, white cells move like an amoeba. So that they have a very flexible cell membrane and they squish along. And then, because of our blood vessels are all leaky, have lots of openings in there, a white cell can slide out of the capillary through a process known as diaphoresis and go track down a pathogen, kill it. That's what white cells love to do. They like to kill things. They are drawn to pathogens, viruses, funguses, bacteria. They are drawn to them and they will do their very best to destroy them for us. If our white cell count goes up above 11,000, then that means we have an infection. Here, generally somewhere around 5,000 is a normal white cell. 5, 6, 7,000. Get up around 10, 11, 12,000. That's fine if you have an infection going on somewhere. You may not even know that you have an infection, but white cell count comes back at 11,000. Well, you're probably got an infection somewhere you may not even be aware of. You're fighting an infection. Your immune system is at work. It's produced a certain number of white cells to destroy whatever the pathogen is. That is a perfectly normal response. When we get concerned is if our white cell count shoots up to 100,000. We're not going to get excited about 10, 11, 12, 13,000 white cells per microliter. We're going to get concerned if it goes to 100,000 or more. And that's only when we have a malignancy, usually. So what are the white cells? How are they made? Well, there's 2 different types. There are cells that are called the granular granulocytes, meaning they have lots of little granules in their cytoplasm. And you have the agranulars. Guess what? They don't have any granules. So granular and agranular. There are 3 granulocytes and 2 agranulars. The way to remember the most common type of white cell is this little mnemonic: never let monkeys eat bananas. Neutrophils are the most common. Probably 60% of all of our white blood cells are neutrophils. They show up first at the site of an infection, and they last for 2 or 3 days. They're the first ones there. Lymphocytes are about 35% or so of the white cells. The lymphocytes are the true infection fighters. The T cells and the B cells we hear talking about in different diseases. The T lymphocytes and the B lymphocytes. The T lymphocytes became immunocompetent in the thymus gland to fight infections. The B lymphocytes became immunocompetent to fight infections in the bone marrow. It is the B lymphocytes that produce antibodies, and the T lymphocytes that are the cell destroyers, if you will. Monkeys, monocytes. Monocytes turn into big macrophages, and so if you have dead tissue or damaged tissue, the monocyte will come along and dissolve that. The eosinophils, parasite fighters. They will attack parasitic worms in particular. And then the last category, the one that's almost impossible to find on a blood smear slide. And I call it a blood smear, they call it a blood smear So if you put enough blood on a slide, and you put the stain on it, and then you take the cover slip and smear it across there, and it dries, and then you look at the cells, and you can count them all up. You know, it's all done automatically now. But it used to be, you know, a long time ago, you would have to set a microscope and you could flicker it back and forth back. Because 1, 2, 3, 1, 2, 3. And you count up the number of cells you can see go here. The microscope slide had a grid etched into its glass so that you could see it. My physiology professor in college made us do that, even though nobody was doing it anymore. He made us do it the old way, just so we could see how tedious it was that they were flickering with the cells. So, I've never forgotten. I eventually did forgive him, but I never forgot that. So anyway, okay, and then so the basophils look like little blackberries, you know, like clusters of black. You know what a blackberry looks like? Not, you know, with all the little seeds and everything and little bumps. Well, that's what a basophil looks like, and that's going to be part of your allergic response. And we're going to talk more about each one of those. So if you were to take a sample of blood and you spun it down, you would have your plasma on top. You would have a thin white layer called the buffing coat sitting on top of the red cells. The red cells make up 45% of your blood. Plasma makes up 55%. The remaining less than 1% is going to be the white cells and platelets. And then you're going to, and this is the, you can see neutrophils, somewhere between 50 and 70, lymphocytes 25 to 45, monocytes 3 to 8, eosinophils 2 to 4, and basophils coming up last. Never let monkeys eat bananas. That is the sequence in here. Forget whether they're granular or agranular. The most common are the neutrophils, the least common are the basophils. So here are your granular leukocytes. They have very prominent granules in their cytoplasm that suck up various stains that we use. You have to put a stain on these slides or else you won't see anything because they would appear almost transparent. But different types of white blood cells accept different types of stains. And so some are, that's why some will stain purple, some will stain red. It just depends. Now, the neutrophil, the most common type of white blood cell, has a 3-lobe nucleus, at least 3, maybe more. Very, very obvious to look at. Anytime you look at a blood slide, you're going to see a neutrophil, and at least one neutrophil in your field of view. And they're very common. The eosinophil is going to have 2 lobes. You're only going to have 2 lobes in the eosinophil. It tends to stain a little redder because of the dye. And then the basophil has lots, you know, usually the nucleus is much larger than they show in the diagram there. And the granules on top of the nucleus make it, I like to think it looks like a blackberry. So here's the neutrophil. The neutrophils are our bacteria killers. The neutrophils will, they'll come out first during infection, and they will sneak up next to a bacteria, and they will shoot oxygen directly into the bacteria. Here's the bacteria right here. These are rod-shaped bacteria that we see. This is a neutrophil, and it's injecting oxygen right into the bacteria, and the oxygen turns to bleach. It is oxidized to bleach, and it kills the bacteria, or it turns it into hydrogen peroxide and kills the bacteria. So they're great for a bacterial infection. You get a cut, you get a scratch. You get bacteria. Anytime you have penetrating into the skin, you're going to have bacteria. coming in, and neutrophils are gonna glom on that site immediately, and they're gonna start killing the bacteria as fast as they can. That's what they do. And so, that's what, and these neutrophils are our first line fix. Now, the eosinophils, they look like, two lobes in here. They go after parasitic worms. Someone has an infection of roundworms, or they have an infection of tapeworms, or anything like that, then the eosinophils will start dissolving away the worms. That's what they do. They kill the worms. And so if you have a patient with a high count of eosinophils, you may want to think about some sort of parasitic infection going on in them. So important indicator here. Normally they're never, but this is like the next to least common type of white cell. The basophils are the least common type. The basophils, and this is a better illustration. That's why I think it looks like a blackberry. So the it is a very purplish black structure in here. The nucleus seems to fill up the entire cell. What it does is it can release histamine and heparin. Heparin is our body's natural anti-coagulant to prevent platelets and forming, coagulate, foreign and bonding. An anticoagulant prevents the population. The generic term is blood thinner. It doesn't really thin the blood. Heparin is a natural anticoagulant. The granules either contain histamine or heparin. Now, histamine is a trigger for the inflammatory response. We release histamine, it causes our blood vessels to dilate, causes them to become leaky. So we increase blood flow to a region. White cells can move out through the leaky capillaries in here, and we can fight some sort of irritation, some allergic reaction. We are allergic to pollen. So the pollen triggers our histamine receptors in our nose to release histamine. These basophils are releasing histamine, and our nose runs. On a systemic basis, if it's a body-wide response, I mean, if a patient is allergic to these things, they get stung by a bee, and they have a massive release of histamine from these basophils. And there is a systemic vasodilation. The blood vessels enlarge, and they become leaky, and plasma leaks out into the tissues, and the patient swells up. The whole basis of swelling after a bee sting is because of this response to histamine, a massive histamine response. It will swell up. The plasma is leaking out of the tissue, out of the blood vessels, and leaking into the tissues. The tissues swell. What's happening with the blood when you lose the plasma? Well, the blood volume is dropping, heart rate's going up, trying to compensate for the blood loss. Now, from the fluid loss, the red cells are still there, but the fluid loss is put down. So. And they don't last long either. Those are the basophils. They are the least common type of white cell. Now, these are granular. The neutrophils, the eosinophils, and the basophils are granular. The agranulars are the lymphocytes. The lymphocytes are the infection fighters. They're the only cells in our bodies that will kill other cells. So, white cells, neutrophils will destroy bacteria. Eosinophils will attack parasitic forms. Basophils will release histamine and heparin. The macrophages will, we'll see here in a second. The monocytes are going to destroy dead tissue, take it out. But the lymphocytes will attack living cells and kill them if they're infected. If they're infected with a bacteria, if they're infected with a virus, if they have a malignancy growing inside them, they'll try to anyway. the lymphocytes will attack these cells and kill them. They're the only cells that kill. So in fact, some of them are called natural killer cells. And there's two categories, T lymphocytes and B lymphocytes. T cells, white cells that mature in the thymus gland. The T cells are the only true killer cells. The B cells produce antibodies. Antibodies are a protein. Talk about that in blood typing. Antibodies are a protein that will react to a foreign cell. A foreign cell will have a foreign antigen. The antigen is the marker on the cell that says, hey, I'm whatever. We all have our own cells, our bodies, and all of our cells have the same marker saying it's us, so our immune system doesn't attack us. But a foreign cell would come in, and our immune system would recognize that cell as foreign because of its antigens, and we would start producing antibodies. The antibodies are going to target the foreign pathogen for destruction or block its action. That's how antibodies work. That's how vaccines work. You get a flu shot, for example. You get a flu shot and you don't get the flu. So you get a flu shot. You don't get the flu from a flu shot. Well, what you do is you trigger the production of antibodies from these B lymphocytes. So that when you are exposed to the flu, you don't become symptomatic. You don't get sick. So the lymphocytes, they have a very large nucleus, very common, very easy to spot. It may look like they're granular, but they're not really granular. And they're going to, if you're seeing several of these in a field of view, then they're not basophils, they are lymphocytes. And then the monocytes have a kidney bean shaped nucleus. The monocytes are the macrophages. They are the destroyers of viruses. They're the destroyers of bacteria. They're the destroyers of dead cells and dead tissue. And they will take out, you have damage from a penetrating injury, the monocytes will come in and clean up the mess. They also can detect foreign pathogens and turn on the lymphocytes to give you a response. Monocytes last a long, long time, several months at least. Now, there are two different categories of leukocyte problems: overproduction and underproduction. Two most common overproduction leukocyte diseases are going to be leukemia, which is a malignancy of the bone marrow that we overproduce white cells. Now, the problem with that is some is good, more again, it's not better, because you're overproducing white cells that are immature, and with the leukemia, you overproduce white cells that are immature, they can't function, and you are excluding the production of red cells. And untreated, your patient will die. The other condition is infectious mononucleosis. Okay. Now, what's the difference? Well, here's a leukemia. You're looking at a blood smear here. You see a bunch of purple cells. They're not distinct. They're not differentiated. They all look the same. Here's one that's in the middle of mitosis. Shouldn't be doing that. Here's another one in the middle of mitosis. Here's another one in the middle of mitosis. And so if you were looking at a normal blood smear, you would see one white cell, typically a neutrophil. These are undifferentiated, meaning there is no distinction as to what they are. You can't tell if they're granular or agranular. You don't know what kind of white cell it is. So we've overproduced abnormal white cells. You should only see one in a slide. In a field of view that's showing there, you should see one. And it should be packed full of red cells. You also notice that there are not nearly enough red cells in here. This thing should be filled with red cells. So what we're doing is the bone marrow, the malignancy of the bone marrow that's causing an overproduction of white cells, is excluding the production of red cells and platelets. And so your patient will be tired. They'll short of breath. They will, they, in the mucus, in the membranes, they're going to show, they're going to be pale. So all these things, their red cell count will be down. Their hematocrit will be lowered because they don't have a lot of red cells, because the bone marrow is overproducing these immature white cells. There is no infection fighting properties. A patient with leukemia is going to die untreated. Everybody with leukemia will die if it's untreated, usually from some sort of opportunistic pathogen that comes along, like a cold virus. A rhinovirus that causes the head cold. There is no immune response, and that will very quickly degenerate into pneumonia and kill your patient. And that's what happens. You can't fight infections. You have no strength to fight infections because you don't have enough oxygen, because you're not producing enough red cells. And these immature white cells are crowding everything else out. So, and this is what our leukemia looks like. Now, it usually comes in two categories, either an acute leukemia or a chronic leukemia. Acute leukemias are fast growers, usually affecting children. The chronic leukemias, on the other hand, are slow growers, and we see this in older people. The acute leukemias are going to grow quickly from the stem cells, the hemocytoblasts, that are going to produce the all 7 formed elements. You'll see rapid growth and proliferation. Now, the good news is that the treatments are fairly effective. Survival rates are well under the 90% range. 50 years ago, 60 years ago, mortality rate is about 99%. Very few people survive. It's quite a long time. Now it's pretty much good. It's unusual for these days to hear someone who died of leukemia. It still happens because the survival rate, while it is probably somewhere around 95%, there are still 5% of the population that has it that are going to die. The white cells don't fight infection. Their red cells are not present in sufficient quantities, and again, some infection will come along that we would either not even be aware of, or just make us symptomatic for a few days and then go away, and that would kill the patient. Usually in some sort of overwhelming infection. But again, also, since there are no platelets, we could bleed out. Stem cell transplants, bone marrow transplants, they work. There's all sorts of chemotherapy and radiation treatments that work to get us to that 95% survival rate. Okay, last disease here, we'll take a break. Mononucleosis, commonly called mono. It is a highly contagious disease, very contagious. Often referred to as the kissing disease. You can share spit with someone who has mononucleosis, and guess what? You just gotten infected. And you may find it off, you may not develop it, you've been exposed to it, but if you do develop it, it is a viral disease. It's called the Epstein-Barr virus, or Epstein-Barr virus, okay, depending on how you say it. This will overproduce, this disease will overproduce lymphocytes. Originally, the reason it's called mononucleosis is initially it's a monocyte syndrome. But then it was discovered that the lymphocytes, that name had all just out to say it's mononucleosis ever since. Still called mono. It is, you're overproducing white cells, you're underproducing red cells. The patient will have an enlarged spleen, they will have a low-grade fever, and they will be tired for about 2 months. And then gradually your immune system will run its course, will respond, and fever goes away, and tiredness goes away. And for some, it can last as long as 6 months. The average is about 2 months in here. Um, Generally confining you to a lot of rest. If you're very fatigued, you have this condition. It usually is, the biggest concern, of course, is perhaps if you try to be too active while this is going on, you may end up rupturing your spleen. So you're pretty much confined to bed, or at least not doing anything. So, but it is highly contagious. It spreads through schools all the time. Particularly, if you're a 4-year school, a resident school, you have dormitories. Zooms through there, zooms through high schools. Lots of people develop it, then it goes away. So, okay, let's take a break. We'll stop here at platelets and pick up in about 10 minutes. So. Oh, yeah, how about with my dean downstairs, so. Okay, let's talk about platelets. Platelets are cell fragments. They come from, originally from the hemocytoblast, the stem cell. The cell that produces the platelets is called a megakaryocyte. And platelets are nothing more than cell fragments that are designed to trigger some sort of clotting process. Generally we have 400,000 or 500,000 platelets in a microliter of blood. Their primary role is to form a plug, a platelet plug that is designed to stop bleeding temporarily. It's not a permanent fix. Now, platelets can cause problems for us. We'll get into those shortly. In unusual circumstances. We generally keep our platelets under control because we don't, platelets circulate through our blood. If the platelet is inactive, it's fine. No problems. If a platelet becomes activated, it will start calling in all its friends and neighbors. It is a positive feedback mechanism where one platelet calls two, and two call four, and pretty soon we have a clot or a plug flowing. But normally, our blood vessels are busy producing nitric oxide from, nitric oxide is a very, very powerful vasodilator, keeps the blood vessels open. It also prevents platelets from sticking together. And the inside of the blood vessel will release prostacyclins, which also is sort of an anti-stick mechanism. So we generally don't have issues with platelets normally. At least we shouldn't anyway. So this is how they form. There's your hemocytoblast there on the left-hand side. The megakaryocyte forms, and then just fragments of the megakaryocyte break off, and that's what a platelet is, nothing but a cell fragment. Platelets form, and they degenerate in about 10 days. We are continually producing platelets. Platelets can be harvested from blood. You can be a platelet donor. You can be a blood donor. You can be a platelet donor. You can have the platelets harvested from the plasma and everything returned back to you also. So platelets then can be administered to someone who is deficient in platelet production. Okay, so we have that's platelets. It's not much to it. The role is to form a temporary plug, a band-aid, if you will, over the site of an injury, an injury to a blood vessel. That's their role. So you have a trauma to the skin. You have bleeding. We don't like bleeding. Uncontrolled, it ends badly, but we want to stop the bleeding itself. We have a very sophisticated, very elegant procedure to control our bleeding. We have what's known as the vascular spasm, which is the first step, and it's exactly what it sounds like. The blood vessel quivers, and to try and stop the bleeding. We form a platelet plug, and then the ultimate step is the actual formation of the blood clot, the coagulation phase. So, vascular spasm. We have an injury. The blood vessel is surrounded by smooth muscle. It has two layers of smooth muscle surrounding it. Every vessel except capillaries, whether it's an artery or a vein, has smooth muscle around it, and that will contract, and it will try and squeeze the vessel. And so when you have a trauma to the vessel, you have penetrating injury to the skin, trauma to the vessel has been punctured, And so the smooth muscle will contract. And that will try and close the injury. That's the first attempt to slow down the bleeding. The triggers, well, if you penetrated the blood vessel, you penetrated the smooth muscle layer. That's going to be a trigger. Smooth muscle doesn't like being penetrated by sharp objects. And so the smooth muscle lining the vessel will contract rapidly, trying to close the injury. If you damage the smooth muscle layer and you're bleeding, you damage the inside lining of the blood vessel. And so the inside lining of the blood vessel is where you're going to release, where you're releasing nitric oxide and prostacyclins. The damage to those tissues here triggers a spasm. And it hurts. Penetrating injury to our skin usually hurts. So pain will trigger this spasm. So the whole idea is for the vessel to close at the site of the injury. And in many cases, that's all it takes. There are many times when we've been injured where we've cut ourselves. Frequently, we're unaware of it. We see, oh, where'd the blood come from? Yeah. Who hasn't seen, I'm bleeding and it doesn't hurt. Why am I bleeding? We've all had that experience. And it stops. Usually because you've had this spasm. Spasm is the first line of defense here to control bleeding, and it works very well in small vessels. It doesn't do much for capillaries, but then capillaries sort of shut down anyway. But if we're dealing with venules or veins, veins and venules are the smaller veins. If we're dealing with venules or veins, first of all, the pressure's low. You're not going to have a lot of high pressure blood coming out from a vein. And it's gonna, if it's a small vein, it's likely going to close on its own. If not, then we have to go to the next step. So let's assume we have a penetrating injury to a blood vessel and we're bleeding out slowly, or we're still bleeding out. We've gone through the vascular spasm and nothing's working yet. It's still bleeding. So the second step is what we call the platelet plug formation. And what we're seeing here, there's the injury at the top, some sort of penetrating injury to a blood vessel. We have our vascular spasm. You see step 2 here, we have the vessel constricts to try and stop the bleeding. The next thing is the platelet plug that we try. Platelets become activated when the basement membrane underneath the line of the vessel is exposed. And our blood vessel has a very smooth layer. This is a blood vessel. We have a basement layer here. We have an endothelial layer here. This is our inner lining right there. And it's a non-stick surface, if you will. If we penetrate that, with some sort of sharp object, we're now exposing the basement layer. So what will happen is if this basement layer is exposed, that will activate circulating platelets and start making them sticky and attracted to the injury. So here we see we've got the damage right here. We've exposed the basement layer underneath the lining, and that will activate platelets. That will trigger the platelets to start coming over to the side of the injury. They're not going to respond if that layer is not exposed. And we're not going to get a platelet plug form if there's no reason to form. So what happens is that when the basement layer, which contains collagen, when this basement layer is exposed, the collagen is present, and the platelets respond to the presence of the collagen. The collagen triggers them to work. Now, if the collagen's not exposed, then there's no problem. If the lining is, if we don't penetrate, we just hit the smooth muscle layer, we don't penetrate the inside of the vessel, it hurt maybe, but we didn't expose the basement layer. The prostaglandins and the nitric oxide are keeping the platelets from sticking. But if we penetrate into the interior, into the lumen of the vessel, then we're going to expose the collagen layer, the collagen protein layer in the basement layer of the blood vessel. Because we have the outer layer, we have the basement layer, which is underneath, which is you got the outer layer, smooth muscle, then you have the collagen fibers, and then you have the non-stick surface, and then you have the lumen. If we expose the collagen fibers, which are the protein layer, then we're going to activate the platelets. So we don't want the platelets to stick together. And this is a better picture here than what I threw up on the board. But so here we have our blood vessel right here. This is the outer lining. Here's our smooth muscle. Here's our collagen layer right here. And here is our inner lining, the intact, as I say, the endothelial layer. It's epithelial cells. It's simple squamous epithelial, but because it's internal, we call it endothelial. So we penetrated this layer here. We damaged all the way through the outer layer of the vessel, the muscle layer. We exposed the collagen fibers here. The prostacyclin and nitric oxide are protecting all the other parts of the vessel. But right here, when we had the penetrating injury, we're activating. We're not going to activate the whole length of the vessel, because where it's intact, we're going to be busy secreting prostacyclins and nitric oxide. Those are the non-stickers, if you will, the non-activators. But here we go. The collagen fibers attract the platelets, and as soon as they start sticking together, they start releasing platelet factor. Platelet factor, number 2 on the list here, platelet factor attracts all the other platelets. Hey, come on over. We're having a get-together on this vein. So come on over and join us. And so they do. And as more and more platelets come over, they release platelet factor and attract more platelets. And pretty soon you end up, what we have here is a platelet plug to block the hole. That may be enough. Maybe. You know, if it's a small cut, a small injury, that may be enough to stop the bleeding completely. So, but it is the exposure of the collagen fibers underneath the non-stick surface layer, the inner layer of the vessel. When that collagen layer is exposed, that's what's going to turn on the platelets. So platelets, when they're activated, become very spiky and sticky. Like, you know, you let the dog run in the woods and come back with burrs all over them. You're pulling it out of their hair, and they have all these little spikes sticking out of it. You know, that's what platelets look like. They have, they're very spiky and they stick together. And as they become more and more sticky, they become more and more activated, and more platelets coming in. They're all going to be attracting each other. And this is great. If the cut is small, if the injury is small, that may be all we need. A platelet plug will stop the bleeding, and then we can repair it. But if that isn't enough, the third step is coagulation, blood clotting itself. Blood clotting will form over top of the platelet plug. It will reinforce the platelet plug by forming strands of protein called fibrin. This is where we get into the definition of blood as a connective tissue. The connective tissue is living cells in a matrix of fibers. We've got the formed elements, they're living cells. The matrix is the plasma. The fibers are in solution. And it's a two-step process to get the fibers to form. So we convert, when we form the fibers, we're actually going to coagulate the blood and turn it from a liquid into a gel that fits into the opening and stops bleeding the clot. Remember the blood clot yesterday, shaped like the bronchi that someone coughed up? Well, that's a clot formed by the fibrin, the fibers squeezing this mass into this something like jello, if you will. So how do you get a clot to form? Well, there are two pathways. There's the intrinsic pathway and the extrinsic pathway. They both end at the same spot. You get a clot. Both are caught when you have tissue damage. You're going to get both pathways. The bottom line is that whether it's the intrinsic pathway or the extrinsic pathway, you are going to turn on something known as prothrombin activator. Prothrombin activator will convert the protein prothrombin into thrombin. So that's what both of these pathways will do. They're sophisticated little elegant procedures. The intrinsic pathway, we call it that because all the clotting factors involved are within the blood itself. The extrinsic pathway requires clotting factors that come from outside the blood. It's like the addition of calcium, for example. Here are the two pathways here. The extrinsic pathway on the left has multiple steps here. The platelets are going to trigger that. The presence of the platelets inside the vessel will trigger the intrinsic pathway. The extrinsic pathway is triggered by damage to the tissue. So the formation of the platelet plug will trigger the intrinsic pathway. We're going to go through a series of steps as the platelets try to form a plug, and we're going to end up at the bottom where we have prothrombin activator. On the right-hand side, the extrinsic pathway means damaged tissue. And it's the tissue factor that leads to the clotting process, leads to prothrombin activator. But both mechanisms work to get you to the same place. One depends on platelets, one depends on tissue damage. So we're going to have both pathways moving very quickly to turn on prothrombin. Prothrombin activator turns on prothrombin and converts it to thrombin. Thrombin is the active version of prothrombin. Prothrombin is inactive unless it's been acted on by the two pathways. Once prothrombin is activated, it turns to thrombin. Now, that still doesn't give us any kind of clotting. Thrombin acts on the soluble protein fibrinogen. So prothrombin is in solution, fibrinogen is in solution. Nothing's happening to them. The prothrombin will be turned on by the injury. Prothrombin will become activated because the injury, trauma to the vessel, the injury will cause the formation of prothrombin activator. We turn on the prothrombin, it is converted to thrombin. Thrombin then acts on fibrinogen, and fibrinogen is converted to its active form known as fibrin. This is what the clotting fibers are made of fibrin. It's a protein, but it's a fibrous protein. We have this multi-step process here so we don't form clots randomly in our bodies. We don't like clots forming when we don't need them. We only want a clot at the site of an injury if necessary. So you have to get a clot to form, to get fibrin, you have to turn on the prothrombin and so it becomes thrombin. Thrombin has to turn on the fibrinogen so it can become fibrin. So we have at least two steps to go through before we can even get to the fibers. Now the fibers look like this. These are the fibrin strands forming a meshwork over the injury. We have red cells trapped in there. We have white cells trapped in there. We have platelets trapped inside here, and it forms this mesh over top of the platelet plug. And it's essentially like throwing everything in they can grab to seal the injury. That's the first part of it. We trap plasma in here. So even the liquid plasma, which is sort of converted to jello, as is the start of the process here, we turn it into a gel, and the fibers, they cross each other, they start, and then they're forming this web, like almost like a spider web, if you will. And then the clot that's formed will start to contract. So we have this clot formed, and within an hour of formation, clot will start to contract and start squeezing, and it will squeeze out serum, which is plasma, out of the clot. And so the clotting proteins stay in place, but the serum is squeezed out. So within an hour, we have this gelatinous mass plugging the hole, the opening. And why is it clot? Well, because the protein actin and myosin in number 381, those are your contractile proteins, all the muscle contractions. We're not using muscle cells here. We're using these proteins that are in the platelets themselves to squeeze the clot. And so by squeeze, we wrap this mesh of fibrin around the platelet plug, around the side of the injury. We start squeezing, we start drawing the edges of the damaged vessel together. We squeeze out all the water, that's what serum essentially is, it's plasma by itself. And then we have healing starting. We release something called platelet-derived growth factor. The platelets, so here we've got the platelets. They get activated, they form the platelet plug, they attract all their friends and neighbors. They trigger the onset of the intrinsic pathway, the damage caused to the tissue causes the extrinsic pathway. So the platelets now contain the actin and myosin to squeeze the clot. And the next thing they're going to do is they're going to release platelet-derived growth factor to stimulate cell repair. We see new cells being growing. We are repairing the damage to the smooth muscle. We are rebuilding the whole blood vessel wall. So the platelets are triggering that. That platelet-derived growth factor says, okay, let's repair the damage. We start that right away. Then we start producing growth factor for the endothelial lining. So we rebuild the smooth muscle, we rebuild the external surfaces, we rebuild the non-stick surface on the inside of the vessel itself. And this is all taking place within the first hour after the damage, after we stop the bleeding. And the clot itself actually has a built-in mechanism to tear it apart when it's no longer needed. Fibrinolysis, the lysis of the fibrin, will start about 2 days after the clots form. So within 48 hours after you form the clot will start breaking itself apart. The clot contains plasminogen. Plasminogen is a protein that, when activated, is converted to plasmin, which is an enzyme to start breaking the clot itself. So plasminogen becomes plasmin in about 2 days, starts dissolving fibers. And we use what's known as TPA, tissue plasminogen activator, to turn on the plasminogen to become plasmin to dissolve away the clot itself. And TPA plays a big role for us also in breaking up clots that form unwittingly, like a clot in the brain, it causes a stroke, a clot in the heart that may cause a myocardial infarction here, what we generally refer to as a heart attack. TPA can be used for that, also synthetic TPA. Now, we don't want our clots to get too big. We don't want to see what we saw yesterday in lab. Yeah. That was an unfortunate circumstance for the individual that had that clot. So, a lot of things are going on here. Blood is still moving. blood is diluting away the platelet factors so that they don't trigger more platelets. We want to keep the platelet plug and the clot at the site of the injury. So we are washing away essentially the clotting factors. Clotting factors that have formed, we are then breaking them down. They're becoming inhibited. The amount of thrombin that's being produced to turn on the fibrinogen is essentially shut down. We're not making any more thrombin. The prothrombin, no more prothrombin is being converted to thrombin, so we're not converting any more fibrinogen to fibrin. We don't want the clot to become massive. We don't want to have a clot that runs the length of the vein. We want to keep it localized. So we're shutting down the thrombin production. If we do get any thrombin loose in the blood supply and the plasma, we have a fix for that. It's called antithrombin 3. Antithrombin 3 will essentially destroy any thrombin that may have leaked out. So if we have thrombin floating through the system, anytime we encounter fibrinogen, we convert that to fibrin and we form a clot. So we don't want that. We want to have a clot right at the site. So that's what we do. Antithrombin 3 essentially is helped out by the basophil. Remember basophil? I said it releases heparin and histamine. Well, the heparin at the site of the injury is gonna, well, it sort of sounds counterintuitive. Heparin is an anticoagulant. It's an anti-clot drug. There are a lot of ways. Wouldn't it seem obvious that it would have a thought of bringing out that we don't want to have any heparin around because we bleed? Well, the problem is that how are we going to get the damage repaired if we stop blood flow? Heparin increases blood flow. It prevents the clotting, keeps the clot from getting too big because we want to enhance blood flow into the site of the injury. After we get it completely stopped, we want to bring in white cells to kill bacteria and to take out dead and dying cells. We want to bring in glucose. We want to bring in oxygen to promote repair. This is what the heparin does. Heparin helps to limit the size of the clot. It also works with antithrombin 3 to make sure we don't lose any thrombin out in the general supply. And even if we do lose a little thrombin, it becomes so diluted that it doesn't have any purpose. So while it does sound counterintuitive, hey, I got a cut, I'm going to release some heparin so I can bleed more. But that's sort of the idea, so that to promote the healing. Now, normally we don't want to have a clot. Don't need clot on healthy tissue. We make sure that by first of all, the surface of the lining of the blood vessel is nice and smooth. I say it's a no-stick surface. Essentially what it is, because endothelial cells that are smooth, have no rough edges for a platelet to land on, be irritated by. So that's the first thing we do. We're secreting nitric oxide. It's a vasodilator. It keeps the vessel enlarged, dilated, so blood can flow through there smoothly. Prostacyclins keep it from being sticky. Vitamin E, also in our diet, vitamin E it also functions as an anticoagulant, so that we are not sticky. Now, this does become a problem for some people because some people will take vitamin E in excessive doses. Hey, it's a vitamin. How can it hurt us, right? All vitamins are good, right? They're good. Right? Thank you. All vitamins are good, except vitamins in mega doses. Remember, vitamin E is a fat-soluble vitamin. We store it. And a person who takes excessive doses of vitamin E can alter their body's, their blood supply ability to control their coagulation. They can become, in a technical term, very squishy. They bleed easily. They won't coagulate properly if they're taking mega doses of this. Remember, it's fat-soluble vitamin, doesn't wash out in the urine like vitamin C does or vitamin D does. This is stored. And so someone who is taking, over-the-counter vitamin E supplements, mega doses of vitamin E, may run that risk. This is a big problem you have with uncontrolled self-medication, because some is good. More isn't always better. So anyway, normally though, our vitamin E levels are fine. We get a daily dose of vitamin E, and it works as an anticoagulant, and it protects us from forming random clots, which we don't need. Problems. Who hasn't had a bruise? We all get injured. We've all had bruises of one form or another. A bruise is simply a rupture of the vessels underneath the surface of the skin, and there's some bleeding out, and we see it turning purple and green and yellow over time as it gets better. We run into things, we fall down, or we get hit by something, or we just, we hammer our thumb by accident. We do things, and so we get a bruise. There's a purple little sign there, little bleeding into the tissue, and then it heals up and goes away, and there's no issue. However, a extensive injury, large bruising, might cause enough vessels to bleed that would form a hematoma. A hematoma is leakage of blood into the tissue spaces, and you get something the size of a baseball or more sticking up out of your knee, for example. Blunt force trauma, the same type of blunt force trauma that caused a bruise, can lead to a hematoma. This swelling because you damaged so many vessels. If they're bleeding out, the blood has to go somewhere. So here we see very extensive bruising right there. You can see a large amount of the purplish. You can see the purple and yellow over here. This is the breakdown of the hemoglobin right here, showing the yellow. It may turn green after a while. We've all seen bruises. This is a large reason, but this is what a hematoma looks like. This is a hematoma of a knee, which is probably about the size of a baseball here, swollen, filled with blood from damage to the vessels from some sort of blunt force trauma, which will eventually go down as the blood is gradually removed. In severe cases, it might require that blood to be drained out. So that blood is trapped in there for a while. Okay, questions? Who hasn't had a bruise? Right, okay. Problems with hemostasis, meaning problems with normal blood cell formation and activity of movement of blood. We have what are known as thromboembolic disorders. Thromboembolic, I'm saying that right? Embolic, whatever. The first one, we form clots when we don't need to, because it can happen. Clots can form in undesirable locations. A good example is a deep vein thrombosis. Clot, in the veins of the lower legs. Pressure in the veins are very low anyway. And for example, if you were to take a long trip and you're seated in a car, or maybe you're flying to Australia, whatever reason, nonstop, and it's 12 or 8 down, you don't move your legs. You're afraid to get out of your seat because if you unbuckle your seatbelt, the plane will drop off. There are people who believe that, who never leave their seat in the plane. So the legs are bent for 12 hours. Right behind the knee, you have the popliteal vein, you have the posterior tibial vein, and all these veins are going to be compressed because your leg is bent. And eventually, sometimes, that bend and the narrowing of the vein will cause a platelet to hit it and bounce against it and become activated and start bringing in other platelets. The next thing you know, you have a clot behind the knee or in your upper thigh, and that can lead to what we call acute vein thrombosis. Thrombosis is a clot, and that can block the blood supply returning up your leg. And that's that site. It's pretty unusual to have that. So this is a concern about, long distance travel. You have to move around. The disorder, however, some people form undesirable clots more frequently than others. The chart back there in the back wall says deep vein thrombosis. You can take a look at that if you want. In fact, there's even a picture of a person in an airline seat, afraid to move, forming a clot in their leg. So, what usually happens is the clot forms and the leg will swell up because it's restricting blood flow, and the plasma will pull there and move into the tissues, and the leg will probably double in size around the thigh, around the calf muscle, around the tibia there, and it'll dimple when you press against it. The dimple will stay dimpled, and then after a week or so, it'll go away. Usually, the patient ends up taking some sort of anticoagulant at the same time to get rid of the clot. The danger occurs if that clot starts to break apart and move. Because if it moves, it's going to go up to the heart, and then it goes to the heart, it may go into the lungs. So people that have some sort of disorder run the risk of developing unwanted clots. The other side of this is a bleeding disorder where you don't clot properly. So your problems are, do you clot too easily, or do you clot, or you fail to clot? Do you bleed easily? So you're clotting or bleeding. Those are your disorders here. And then, of course, there's the extremely lucky individual who has those that can occur. So the thrombophilia. This is a sort of a category of people that have some sort of risk in developing a clot, a thrombosis. A thrombosis is a clot that has formed. It hasn't moved, but it is a clot. And so thrombophilia is this predilection to forming clots in the body. If you've had a DVT, if you've ever traveled and had a DVT, then you're at greater risk for another one. So if you have a DVT when traveling, then you have a 50% chance that you have some sort of clotting disorder. Because, which is not really statistically really valid, because if half the people that get a DVT have the disorder and the other half don't, how do you know which one you're in? So we didn't know anything about these until the mid-1960s. No clue as to clotting disorders. An individual who developed a clot, and the clot went to their heart or to their lungs, would essentially die on the spot. They would collapse and be dead. And of course, in the early 60s, nobody knew anything about CPR or defibrillation or anything up here. And so you say, "Oh, Grandpa dropped dead," right there at the dinner table, face down the mashed potatoes. And that would happen. Sudden death. You know why? Because of this clot. Nobody really knew much about it. The factors that make people more prone to clotting, the work didn't start until the 1960s. The first one that was identified was a clotting factor known as factor V Leiden. That is probably the most common of the clotting factors here. These are genetically inherited. And of course, you have to have the recessive traits to have this, but it is, so it's an inherited thing. It's not something you acquire. People with a clotting disorder of any kind are at a greater risk for having a deep vein thrombosis. And most DVTs are related to this factor V Leiden. The concern, of course, is the thrombus going to move. If the thrombus stays where it is, it's not a problem. If it breaks apart there and dissolves, it's not a problem. But if it breaks apart and starts to move, now we call it an embolus. And if it lodges in the heart or the brain or the lungs, then we refer to it as an embolism. And so the biggest concern is it going to go into the lungs and form what we call a pulmonary embolism, which can be instantly fatal depending on the size. And what it will do is the clot will block the blood supply to the lungs and shut down one lung, or maybe both lungs, because the size the clot is large and it starts blocking the pulmonary arteries. Okay, a thrombus is a clot that forms in an undamaged vessel. A thrombus isn't moving. An embolism is a clot that has moved. It has broken apart from the thrombus. So a thrombus, clot forms, that's a thrombus. A clot forms and breaks apart, and part of the clot is moving. Now we have an embolism. So an embolus is a clot moving. An embolism is where it blocks a vessel. Here we see a clot, a clot that has formed in a vessel, and if it moves, which if it does start moving, blood supply in every vein is always going to end up in the heart. All veins return to the heart. All veins return to the heart, and so that blood goes into the heart, goes into the right atria, into the right ventricle, and is pumped directly to the lungs. Now, a clot that comes into the right atria is not a problem for the heart yet. That clot's going to go into the right ventricle. The right ventricle is going to send blood through the pulmonary pump to the pulmonary arteries. That blood goes out to the lungs. Now, this is where a clot, an emboli, it has been brought up to the right atria, to the right side of the heart, can get stuck in the lungs. If it gets through the lungs, it's going to come back to the heart. It'll go into the left ventricle, and then go back out to the blood supply, which will be pumped out on the left side of the heart to the whole blood supply. The first 5% of the blood leaving the heart through the left ventricle goes back to the heart. And now we have the risk of the clot being formed in the lungs. The embolism may have been formed in the heart itself. So you have a couple things that can have shut down the respiratory system because of a pulmonary embolism, or you can have a shutdown of blood supply in the heart because you're blocking the coronary artery. But generally what happens is the blood's going to come up, go into the right side of the heart, go out to the lungs. So lungs serve as a big filter for clots. The third little secret is we're busy generating tiny little clots all the time that don't cause us any problems. They go into the lungs, the lungs filter them out, and they break apart. You never notice. It's only when you get a big clot, a big emboli in the lungs, you have a problem. So who's at risk for developing a pulmonary embolism? Well, anybody, conceivably. The risk factor is higher if you have a clotting disorder. So here's what it looks like. There is a normal artery right there. There's a clot in the artery. It's a thrombus because it hasn't moved. At least it hasn't moved yet. In our leg, this is a DVT. The normal blood flow flows through the leg. We have a series of small valves in our veins that we use to move blood back to the heart. Remember, the pressure in the vein is very, very low. 0 to 10. 0. It's very low. And the heart has nothing to do with getting this blood back. We have to squeeze the veins, push the blood back uphill. And so these valves prevent the backflow of blood. All it takes is a platelet. These little things right here, those are all the platelet has to do is bounce against this valve and discover that, oh, I'm activated, and start calling in all of its friends, and pretty soon you may form a complete clot. Now there's blood passing. This will go away eventually, but the risk is always that part of it may break off. Now you have your embolus. It will travel up to the heart. It will travel to the lungs. If it gets stuck in the lungs and it's large enough, it can form an embolism and block the vessel. And this is what your legs look like with a DVT. And I emphasize this because this is a pretty common condition. So Guess which leg in this picture here has the DVT? Yeah, it's pretty obvious. Because you're restricting the return flow of the blood, the plasma has to go somewhere, so it goes out into the tissues and the tissues swell up. So here we see this. Here we see another one. The leg that's going to be affected is going to be red. It's going to be hot. It's going to be swollen, and you press down on it and form a dimple. The dimple will stay there for a while before it fills back in. Again, we see this one swelling here and the redness. Generally, it affects any of the veins behind the knee, because the knee is either going to be bent, and that's where you're going to get the problem. Deep vein thrombosis may also show up in individuals who have significant varicose veins too. Varicose veins, the valves have failed, and so blood has a much harder time getting back up. The blood flow is slower, giving platelets more times to do something. So, and this is what an embolism looks like. This is a CT, and you see here the areas where marked with the red arrows. During if you ever had a CT, you know they give you some sort of dye so you can have contrast of the images in here. And so if the image is darker, it means the dye is not getting through. So this indicates an embolism here and over here. A nice outline of the blood vessels here going to the lungs. But this dark spot, it should be as white as all this because there's where the dye is located. So we have an embolism here and an embolism here, this dark area, and that indicates the presence of this blockage of the pulmonary arteries. So, and so this is restricting the blood movement into the lungs. Your patient's first symptoms are going to be shortness of breath, maybe slightly cyanotic, very low energy. They're going to have an irregular heartbeat. They may even have an irregular EKG. It mimics a lot of the symptoms of a myocardial infarction, the shortness of breath and maybe pain, or maybe not. Maybe the only symptom is that there are no symptoms. Maybe they're just short of breath. So, but this is a CT is very definitive in determining whether or not we have a pulmonary embolism going on here. Okay. Anticoagulant drugs. We hear the term blood thinners all the time. They don't thin. They work to prevent coagulation. Heparin, the old standby. Heparin has been around for a long time. We generate our own heparin. We still use heparin now as an anticoagulant, usually obtained from pig bellies. So, or pig stomachs. Don't ask me how. Heparin inactivates thrombin. No thrombin, no converting fibrinogen into fibrin. That's how it works as an anticoagulant. Coumadin, the old standby, used to be derived from the rat killer warfarin. Warfarin is a rat poison, and Coumadin, the generic version of Coumadin is called warfarin. So it works by preventing vitamin K from being used. Vitamin K is used to produce clotting factors. So we block vitamin K by using Coumadin. And the big advantage of Coumadin is very inexpensive. The disadvantage is you have to be monitored constantly to make sure that your clotting time is within normal ranges. So you don't want to get too squishy or not. Aspirin, plain old aspirin, is an anticoagulant. It prevents platelets from sticking together. It causes them to become less sticky. So one of the protocols, of course, when someone's having chest pains and shortness of breath is So part of the treatment that will be administered usually by the paramedics is here, eat this baby aspirin, 85 milligram aspirin. And here's a nitroglycerin tablet, vasodilation, and to block the platelets from sticking together. Because if you're having a myocardial infarction, a blockage of the blood vessels in the heart, you want to stop the clotting that occurs. So. Other problems, thrombocytopenia, not enough platelets. You bleed easily. You have splotchy red marks that break out in the face, almost in the pattern of some of the capillaries. People that have a bone cancer may have thrombocytopenia, not enough platelets. If they've been exposed to radiation, ionizing radiation, they've been taking chemotherapy that has suppressed their bone marrow, they may have this spontaneous bleeding in the skin. So that's a giveaway, thrombocytopenia, not enough platelets. The giveaway is the splotching on the skin. What it tells you is the platelet count is somewhere below 50,000. We're supposed to have between 350 and 500,000 or more platelets. Less than 50,000 means we can't clot properly. We can't form a platelet plug when we need it. Other bleeding disorders. If our liver is damaged, if your patient has liver cancer or cirrhosis of the liver, they can't utilize vitamin K to make the clotting factors. So you can't even produce the bile if your patient has cirrhosis of the liver or liver cancer or some kind of liver disease. Why do we need bile? Well, bile breaks down fat into smaller pieces so we can absorb the fat in the small intestine. Without the fat, we can't absorb the vitamin K because vitamin K is a fat-soluble vitamin. Even though we're making vitamin K in our large intestine. Hemophilia, genetic blood disorder where you simply fail to produce clotting factors. It used to be more common, but there are numerous treatments now, genetically engineering platelet factors that will that will allow clotting to occur. Otherwise, the treatment was transfusions, because they're going to clot, they're going to lose blood. Okay. Blood transfusions. We transfuse blood when we need it. We can't sustain too much of a blood loss. If we lose more than 30% of our blood volume, it will cause a fatal shock. So, because our body can only produce red cells and plasma so rapidly, if we're losing blood faster than we can build up, we're eventually going to die. Typically, we don't give whole blood. We use packed red cells where we take out most of the plasma. And so we want to get just the red cells because the idea is we've got fluid expanders we can add, but we want to have red cells to carry oxygen. The problem is that transfused blood only lasts about 30 days, as opposed to our normal blood lasts for 4 months. And okay, we talked about blood groups already in lab, so we'll just go past that and everything we mentioned here. Okay, so that pretty much covers everything that we want to talk about, because we did remember we did talk about blood typing in lab, so we can stop right there and